All right, so then we can go ahead and get started. And then if anybody joins late, we can just admit them late. So this week's subject was movement compensation. And again, so the month of February is all about strength and conditioning. And so for the movement compensations, it's through the lens of an AT. We're not strength and conditioning professionals. We are medical professionals first. So the lens through which we're viewing the movement compensation is through a medical lens, athletic training lens, but then obviously it's encompassed within the strength and conditioning subject as a whole. So then the various movement compensations, like what we talked about last week, there's kind of injury movement compensations and things that people are going to avoid during their rehab. And then there's also injury prevention. So if you see some kind of a movement compensation in a healthy individual, trying to maybe limit some of that asymmetry or trying to improve some of those ranges of motion to reduce the compensation so that you're preventing future injury. So we will go ahead and get started with that. The overview. So the way that I kind of think about asymmetry or the movement compensations is their cause of the movement compensation. So a lot of times that's caused by pain, and you'll see these kind of limping movements or antalgic gaits. You'll see limited range of motion. People don't really like to use things when they hurt. So a lot of asymmetries can be present from pain. If they have a range of motion issue, then they can start to lean off to one side or the other. And you'll see these in a lot of, especially in elderly population, you'll start to see some of these more arthritic changes. They've been kind of avoiding pain for such a long time that they start to develop range of motion issues, or it could be a strength issue. So if they lack the strength to successfully move through a range of motion, for example, in walking or jumping, then they're gonna lean into whatever they're strong. Their nervous system is going to calculate whatever the optimal way for that individual to perform that action is. And a lot of times that nervous system is going to do what's most effective, but not necessarily what's best for health. So the asymmetries typically are caused by one of those three things. There's some other issues involved there. If somebody's had previous injury or surgery, those kind of things in terms of the tissue restructure or tissue remodeling, then those can get in the way. But for the most part, these are the three that come to mind for me. Then that goes into the kinetic chain issues. So if they have an ankle issue, how does that influence their movements at the knee? Dylan, I'm sure you can dive into a bit of a PT lens here with the different causes of kinetic chain compensations, especially in a rehab clinic. You're going to see a million of these cases. So you might have more to offer here than what the AT community would. But just being mindful of if they have an ankle issue, that might lead to compensations at the knee, the hip, and then it could have effects all the way up the spine into the neck and head. So something like a forward head position, or maybe they get into a hyperextended neck as they're running. Maybe that's caused by something as simple as an ankle sprain, or maybe if they have a knee pathology, maybe that's causing issues at the hip. So now they're hypermobile at the hip to try to make up for the lack of mobility in the knee. So again, just being mindful of those movement compensations. It's not always just an asymmetry. It can sometimes be on the same side, and it's caused by an issue up or down the kinetic chain. There's a lot of, I don't know if it's new or if it's old philosophy around the knee, but a lot of people I think it's probably new or old and being recycled as new. And they're saying there's not actually any issues with the knee. A lot of issues or pathologies at the knee stem from bad ankle or bad hip mobility. And so that compensation can create issues with the knee if you have bad ankle or hip range of motion. And then the last piece of it for me is the different planes movement. So you can have compensation not only up and down the kinetic chain, but you can have it in different planes of motion. So the most common that we look at is going to be the sagittal plane. We have people doing, for example, a squatting motion. Are they leaning off to one side? Are they using one hip more than the other and then one knee more than the other? So a lot of times the issues we're looking for are in the sagittal plane, but as we'll get into with the paper later, the transverse plane is another one that kind of gets glanced over, but has a lot of larger implications in terms of the compensation. They talk about the knee valgus, for example, as one cause of pathology, being if you have knee valgus, now it creates a hip internal rotation. Now you're losing out on a lot of that strength and power of the hip, and now maybe you're going to get more force loaded through your low back because the knee is in a structurally compromised position. And then you can also have coronal asymmetry. So you can have compensation if people are trying to lean away from pain. You'll see a lot of this with your routine ankle sprains or anybody with bad hips. You'll see them lean away from that side, and you'll start to see these hip malalignments. So, for example, if you're looking at a Trendelenburg test, for example, you'll see you go into that march position and you see this really big shift off to one side versus the other one's more stable. So SI joints alignment or symmetry is another one that a lot of people will look at there for the coronal compensations. Any questions so far before we get into it? Comments, concerns? So for asymmetries, this picture is obviously really exaggerated. This is some gym coach or maybe a PT who's exaggerating an asymmetry, but what you see is the hips are way out of the center of alignment. So if you just drew a line down the center of this page, you'd see in between the legs, you should see more or less symmetry between the hips, the low back, the shoulders, and then the bar should be flat. One obvious tell is if bar is not flat, there's some kind of a malalignment here. Usually it's an asymmetry either of the shoulders or the hips. Sometimes it's the knees or the ankles, but if you see an uneven bar, that should be a red flag. If you drew a line down the middle of this page, you should be able to see that those hips are basically a mirror image of one another, and that symmetry should be more or less perfect. Obviously, everybody's going to have some degree of asymmetry, but if you're seeing something that's this glaring, you should be alarms should be sounding in your head. But again, to break this down a little bit further, so what I'm looking for with pain, sometimes they're leaning away from that body part. If it's an ankle or a knee or hip, they're leaning onto that other side. Maybe if it's an ankle, they're raised up on their toe to try to avoid putting weight through that ankle and trying to avoid putting force through, especially in that dorsiflex position where you might be forcing some of that fluid into the joint, and then you're going to get a lot more pain aggravation there. So if they're having pain, you're asking those questions. Is this movement painful? Are you scared to do this movement? Or maybe it's not a conscious thing. Maybe they're not aware of it, but maybe it's just a decreased range of motion or decreased force production, and that's causing that. A lot of times with ACL rehabs, you'll see that decreased force production that leads to that shift in the hips, and they're using their stronger knee at that time as a corrective estimate, or the neural system is basically taking over and saying, if I'm perfectly symmetrical, I can't squat to depth. And I need to, if I'm trying to get down to a deep squat, now I'm going to shift onto my other leg to try to accomplish that. And so then you start to basically reinforce those patterns where that side that you're shifting to is now getting stronger because it's taking up the increased force, and the other side is going to continually stay weak because it's not getting loaded properly. So there's some implications there in terms of exercise selection, which we talked about last week, I don't remember. But the exercise selection, maybe you want to go for more of a isolation work to try to tease out that body part, and you're really trying to target the quad on that involved side. Range of motion can be a huge cause of asymmetries. So if somebody lacks ankle range of motion, now they start to take a little bit more, the knee is going to be a little bit more posterior translated, and now they're going to fold more at the hips, and so might get some kind of a rotation, or you might get a really forward hinged position as opposed to a more upright torso. So again, being aware of that kinetic chain, being aware of the asymmetries, just keeping an eye out for those kinds of things. A lot of this can be caused by neural control, and there's some good research coming out now about it, talking about the body's basically ability to trust itself as it goes forward. So if you, and I knew that was going to happen. If your body doesn't trust itself to get into a position comfortably without loading it, then your body avoids that movement, and it won't. Even if you have full range of motion, you won't go through the mobility because your body doesn't trust itself to get itself successfully out of that position. So the neural control with range of motion shouldn't be overlooked. Consider things like the end range strength or the angular strength at the different ranges of motion. They might be strong, for example, with a knee extension, they might be strong at 90 degrees, but maybe they're weaker at 135, or maybe they're weak at 45. So if they need to be strengthened in that end range, then you can play around with that isolation work in that range of motion where they're weak. And then the last thing is the strength. So a lot of times pain causes this, and it's not a true strength deficit. Like for example, if you have an ankle injury, their calf hasn't gotten weaker in a day, but their pain will tell their nervous system to stop recruiting motor units through there that could potentially cause more damage to the sprained ankle. So a lot of times it presents as a strength issue. You throw them in a force plate or a strength test, and they're going to be weaker, but it's not always a soft tissue pathology that's causing that. It can be caused by neural recruitment of the muscle tissue there. Questions, comments? Everything makes sense so far?
Yeah, just a thought. I think sometimes it can be kind of confusing to differentiate if something is a true strength deficit or if it's like a movement quality or movement pattern issue. And in my time working with like ACL rehab, sometimes I've come across issues trying to differentiate, okay, is this person have a true quad strength deficit or is their movement quality just poor? And, I think sometimes it's both, but I was just curious what you think and what you've seen in your experience.
Yeah, I typically try to do the easiest tests first. So for that, I mean, strength is relatively easy to isolate the quad. I mean, especially if you have access to like an isokinetic test, you can for sure tease out, are they weak or even with the different speeds of contraction. So if you have some kind of an angular velocity, where maybe they're going at slower speeds and they have no asymmetry, but then at the faster, you kind of tease out some of those things. I think it's relatively easy to see if they have a strength deficit there. There's some cool devices out there in terms of like the physio world or athletic training world now. You could do something simple like a handheld dynamometer and test their strength. I find that those are pretty inaccurate, and it depends like a lot on how you apply it as the clinician. But there are some other more like stationary dynamometry that's pretty good in terms of you just kick out into a stationary pad that's up against maybe like a squat rack, for example, or you take a strain gauge and you can have them kick out against a stable thing, either a chain or against a some kind of a cord or a rope that's stationary. And you just have them kick out as hard as they can, and you can see, can they truly generate force? Now, a lot of times, again, that they're going to be inhibited by the neural recruitment of the muscle as opposed to the strength. I think you kind of have to use a little bit of a clinical judgment here. Like maybe if you have an MRI of it and you see the extent of the soft tissue damage, or if it's just an ankle joint, for example, or a knee joint. If you have the MRI findings and they don't have any soft tissue associated with it, it's probably not a strength issue. It's probably more of a motor unit recruitment issue. That's not always the case because, like within the ACL, for example, you get a lot of the muscle loss is caused by the neural adaptations through the damage in the ligament itself. So you get the muscle inhibition caused by the neural, and until that nerve heals, if it ever does, then you're still going to have difficulty recruiting motor units, and your body basically has to retrain that neural pathway to recruit despite the lack of that neural feedback or the proprioception in the actual ligament itself. So yeah, good question. I mean, it's tricky, but I think you just have to use everything in your clinical judgment together. So one, what's the cause of, or what's the pathology? Two, what are their maybe their clinical findings in terms of the strength? And then, and lastly, would be obviously the function. How are they translating that force to the activity or task that you're giving them? If it's a squat or jump, something like that. That answer your question?
Absolutely. Thank you.
Cool. I keep getting distracted because everybody keeps walking by on my team, but hopefully that was the last of them. All right. So then the kinetic chain, and again, everything is related to everything here. So I don't necessarily say, oh, if they're having a knee problem, you only have to look at, a lot of times they'll say you have to look at ankle joint and hip joint because it's the joint above and below. But I would look as far up as the C-spine, maybe some shoulder involvement. There's actually, while I was looking for the study for this week, there was a pretty cool paper that was talking about core stability in extremity application and the asymmetries that can present themselves just due to a lack of core stability, not necessarily related to a pathology, but something with like an ankle range of motion deficit was causing an asymmetry in terms of shoulder, like external rotation or something like that. So it's not always just one joint or two joints. Sometimes it goes all the way up. Sometimes it stops. A lot of times it's force relevant. So if the force is being translated poorly through the ankle doesn't have sufficient alignment or strength to reduce that force, then it goes up to the knee. If the knee can dissipate that force, then it stops there. If the knee doesn't have sufficient capacity to dissipate that force, then it translates up into the hip, and then it'll just keep going until that force is dissipated. A lot of times I find that the hip tends to be the end point, and the hip bears a lot of weight and force in just the human anatomy. So it can go all the way up the spine, but a lot of times I find that it stops at the hip, and they'll get a lot of inflammatory presentation, or some kind of a range of motion issue, and they just get a lot of pain and symptom profile in the hip, even though, again, it could have been brought on by an ankle sprain, some kind of a patellar tendinopathy, something like that. The picture on the left here, I think, is a pretty good explanation of it, and it's just one example of the kinetic chain, but where it all starts is the arch dropping. So you get that valgus position in the ankle. So then what does that do for the rest of it? Well, the tibia drops in because it's not being supported. As the tibia drops, you get that knee internal rotation or tibial internal rotation. So now you get the knee valgus. Because you've got the knee valgus, then the pelvis tilts. Because you got the pelvis tilt, the spine is getting an asymmetrical curvature, and now you get the shoulder drop to that left side. Your body is doing all these calculations, trying to figure out where level is, basically. And it's trying to stay upright and level. But as it's doing that, it's taking from one joint to give to another. So that's why you see it, or you can see it go all the way up to the shoulder joint, even if it's something as simple as an arch dropping in the foot. The planes of movement, I think, is the probably most underutilized aspect in, at least in athletic trainers. I'm not sure how much they discuss this in the PT community, but again, a lot of ATs only care about the sagittal plane. Do they have sufficient knees over toes? Do they have sufficient ankle dorsiflexion? Do they have sufficient torso angle in a deeper squat? A lot of ATs are looking at the sagittal plane, and probably with good reason, because I think a lot of movement patterns happen in the sagittal plane, whether that's in the gym or in athletic movement where they're running forward, they're backpedaling, those kinds of things. But I think we overlook the horizontal plane or the transverse plane and the frontal or the coronal plane. A lot of the frontal plane stuff is a little bit easier to see because they're shifting dramatically off to one side or the other, and you can see some of these joints unaligned, and you can see if maybe their hips are higher, one hip is higher than the other, or maybe one shoulder is carried higher than the other. But some of those are morphological, and you can't really rely on them in isolation. So, for example, baseball players, their throwing arm, I believe, tends to hang a bit lower than their non-throwing. So some of these things are just morphological, and they happen due to the activity, but they aren't actually representative of or indicative of some kind of pathology that's happening. So again, using your clinical judgment there to recognize, okay, there is an asymmetry, but it's not necessarily pathological. It's not going to lead to further injury, or it's not going to lead to a re-injury in a rehab context. Some of the joints that you should be looking at in those individual planes are listed here. I think the key one that stands out for me, I mean, you're going to get a little bit of all of these in all of the joints. Obviously, we know the knee isn't a true hinge joint. You're going to get a little bit of that transverse plane where you're getting some of that internal rotation or external rotation of the tibia, and you're probably going to get a little bit of knee valgus or varus, depending on your individual anatomy. But for the most part, it's moving through the sagittal plane. So take these all with a little bit of an asterisk sign. But for me, the key point here, especially in the ankle, is thinking about the ankle anatomy. If you're getting some kind of an ankle collapse, like a varus or a valgus in the ankle, it's mostly subtalar. It's not going to be in the talocrural joint unless you have some kind of a really bad, like a high ankle sprain, where you're getting really bad joint instability that's leading to some kind of a frontal plane asymmetry. But again, just keeping in mind the individual anatomy. If it's, for example, if you're getting into a collapsed ankle, a lot of times with the overweight or obese population, you get that really pronounced ankle valgus position, and you're getting that foot that's really flat on the ground. So a lot of times people will look at that in a clinical context and they'll say, oh, they've got a flat foot, we just need to strengthen the arch. But the arch isn't the problem. It's probably more like the posterior tib, getting them into better ankle alignment, and then gravity's not just going to smash their tibia down into that medial valgus collapse. So again, just using the anatomy. I mean, ATs and PTs have a great understanding of the anatomy. Just take it one step further and apply it into the planes of movement, and kind of think about it in terms of why is this compensation happening? What structures might be involved that are going to lead to this, and then how can we go about fixing it? So in that example, the solution shouldn't be arch strengthening or plantar fascia treatment. It should be posterior tibialis strengthening to get that foot or that ankle into a more inverted position. Questions, comments, anything anybody wants to share experience wise?
Yeah, I mean, I feel like in the athletic training realm, that's something that I've struggled with, possibly in the past 5 years after grad school is when I started to focus more on like these movement patterns that you're talking about. And then also, like you said, not just focusing on like ankle dorsiflexion or things like that. But I do feel like in general, that is something that is lacking in athletic training rehab lessons or whatever it may be. Like even us who had like a longer period of time in school, I feel like I'm just gaining a lot of those principles now and applying them more confidently. But it may also just come with experience, but definitely that's something that I've seen to be a deficit in my rehab process.
Yeah, definitely. Also, like that. And to combine this with that, faster than speed, it highlights the need, especially context for the vertical superstructure and how that asymmetry might be kind of and the details of these rotational compensations that are
Yeah, it just sounds like you're underwater. I'm not sure why.
Sorry about that. My computer has this auto setting. Is that better? Yeah, my computer has this auto setting, which is really annoying. And it tries to mute the background noise, but then it ends up making me muted. So, did you hear what I said or no?
We missed probably like 45 seconds.
Okay, cool. So basically what I was saying is the research is also lagging in this area, and that's why I picked the paper for this week. It highlights that you could have a perfectly good isokinetic testing report, or they could be above 90%, of which is the gold standard there for clearance. Then they could go on to do force plate jumping tests or force production tests, isometric testing, and they could have no asymmetry whatsoever. But then you put them on some kind of a treadmill or a run test, even the Alter G at different body weights, and it teases out some of those asymmetries, especially in the transverse or horizontal plane. So to Stephanie's point, yeah, I don't think it's just the clinicians. I think the research is also lagging these different movement planes. And I think that's something that hopefully, I think this paper does a great job. I hope that more clinicians find value in it. And I hope that it continues to improve in the future in terms of not only the visual recognition of these compensations, but also the objectivity of it. So how are we measuring these asymmetries? And the paper uses catapult devices, or accelerometers to track the asymmetries, which I think is one, but I mean, in all of the different ways to measure force, hopefully we can get some of these different ways to measure range of motion or movement through the different movement patterns. So some helpful literature for this week. There's a list of movement compensations. I think this was just a blog post from somebody who is fascinated by like gym and human movement, but it's pretty helpful. There's a pretty exhaustive list of typical compensations. It's not complete. Obviously, there's going to be some one-offs where people do one thing or the other, but it has I would say probably 20 to 30 typical movement compensations that you're going to see in your rehabs. Recovery and compensation in human movement is a really good publication. This one, I believe, was by a kinesiology group. I can't remember the exact title of it, but Another good read about kind of why the different compensations are happening. And then there's a similar publication just by an individual who's interested in kinesiology, how muscle compensation impacts injury rehab results. And then the last thing I would highly suggest is, if you haven't read it yet, the Anatomy Trains book is really good. Ties together the whole kinetic chain. This is a really good book for, especially for muscle synergists. So talking about how things like the big toe flexor is going to, like flexor hallucis longus is going to influence, for example, the gastroc, which then goes on to influence and tie in with hamstring strength, and all the way up the chain to even to like the frontal bone in the skull. The Anatomy Trains ties together all of these different. They make an analogy basically that all of human musculature or fascial connections are basically like train stations, and they're tied together. They have these long tracks that are tied together with these little stations. So really fascinating concept for how the human anatomy is, but then also really good application in terms of training, rehab, and then compensations as well, if that's something you're looking for. It's an older concept. It's been around for a while, and it's kind of had its rebirth. I know this one was out, and fascia training was like really big in like the 70s, 80s, I think. But then it's kind of gone away. It was disproven. It was called a myth, a fad, and now it's back. Some people blow fascia training out of proportion, and it's not really that important. But understanding the concept of how different musculature works together is, I think, really important. And then 2 video demonstrations. One is a physical therapist who was showing a typical compensation in the squat. So using a more hip dominant strategy and as opposed to a more knee dominant strategy. And this is actually talked about in the strength and conditioning community quite a bit in terms of trying to gain performance. So in like powerlifting, a lot of times you actually want a more hip dominant strategy just because your hips tend to be stronger than your quads. Not everybody. Individual anatomy obviously plays a role here, but the video talks about why some people tend to fold at the hips more and some people squat really deep in the knees. And then the last video is by Squat University. He's pretty popular with physical therapy and strength and conditioning world or injury rehab. And he shows his kind of strategy of targeting the hip shift. So in that first picture we showed where the guy had his hips way off to one side, he the Squat University guys shows his way of kind of correcting that. So the study for this week, the design of this was just a case study. And so it's a professional soccer player, male 26. He was a midfielder and a forward. And he actually had a couple of injuries that led to this rehab case study. So he was 8 months post for a right ACL reconstruction, and they used the contralateral hamstring as the autograft. They also used, I believe, plantaris, if I remember correctly. It was a pretty complex autograft, but anyway, then he was going on for about 7 months, and he started to develop medial knee pain. Well, on the same side, and so then they discovered this meniscal pathology. So they decided to do a medial meniscectomy and took out that medial meniscus. And then he was 4 weeks post-op for that at the time of this rehab testing or treadmill testing. And so what they did leading up to that, they obviously went through a normal ACL rehab. They had cleared the strength rehab, gone through plyometric training, and they thought he was ready to return to running. And they did the limb symmetry index, and he cleared 90% symmetry for all of those different that testing battery. And then he was progressing through underwater treadmill and then also some land-based running mechanics. And he was, according to the physio, AT, PT, whoever was in charge of his rehab, they were describing his movement as symmetrical, non-antalgic. And then basically what they did is they wanted to get some more objectivity. So they put him on an Alter G and progressed the body weight percentage as they kept the speed the same. So they were looking at, as they progressed the body weight, how does that influence his asymmetry? Then the other thing they did is they attached Catapult S5 accelerometers, and these have not only the accelerometer portion, but also the tilt. So it shows the degree of rotation involved in these things. And so in order for the fitting, they taped they had three of these devices. They taped one to the left and right calf at the Achilles musculotendinous junction. And then they also had one in a vest that is the more typical GPS device that's worn through catapult. That's the one that everybody wears, the vest or the harness, and then they just strap it in the back. The treadmill progressions, these were 2-minute intervals, and so they weren't really trying to exhaust or fatigue him. And they chose a speed that was 30% of his maximum speed, pretty slow speed, but it was consistent with their rehab protocol at that time. They typically start people with their running at 30% max speed. There's another famous or popular researcher who does, especially with soccer return to play. I think his name's Matt Taberner, and he had arbitrarily chosen 60% for his testing protocol, but he didn't have any rationale for why he did it. So they just went with their typical rehab approach and just put him to start at 30% of his max speed. Max speed that was targeted, or that was calculated by in-game metrics, so GPS in those game moments. And then they progress the body weight starting from 70% up to 95% in 5% increments every 2 minutes. So what they found, the acceleration and impact was the first thing they were looking at, is as that foot came back into contact with the ground, what were these different accelerations in terms of the vertical, the medial to lateral or the transverse plane, and then the anterior posterior or the frontal plane. And what they found was at 85%, the body weight started to tease out some of these asymmetries. That it increased the magnitude for the vertical acceleration and medial lateral acceleration at 85%. From 70 up until 80%, it was about the same. It wasn't statistically significant, but once they hit 85, it was increased magnitude. And I believe it was 85 to 90, and then I think 90 to 95 was no longer statistically significant difference between those two. So this is in line with previous research that says once you clear 90% body weight on an Alter G, you probably don't need to go up to 95. You can probably successfully put them back onto land running. But there's some different approaches there. Some people say you need to go all the way up to 100% on a regular treadmill first. But interestingly, the 85% threshold or inflection point wasn't the same for every plane of movement, and the anterior posterior started to get an increased magnitude at only 80%. So thinking again critically here, okay, well, if they're going to start to see some of these asymmetries or the higher accelerations at the anterior posterior movement plane, maybe we need to look at a different view. Maybe we need a different vantage point as a clinician. We need to go to the side perspective to see if we're getting some of these asymmetries in the 80th percentile range. Then once they get up to 85th percent or 90th percent, maybe then we go back to a posterior view and we're looking for side to side or vertical acceleration asymmetries. And then the other thing that they measured was player load, and this is a sum of all of the accelerations, all of the different movement planes. And again, interestingly, there's different body weight representations or different body weights represented different player loads depending on which plane of movement you're looking at. And so the vertical acceleration started to increase at 75%, and then it was asymmetrical all the way. So the vertical forces showed asymmetry regardless of body weight. The medial lateral only started to show a statistically significant difference at 95% of body weight. And that's when it started to show increased acceleration forces. And then lastly, the anterior posterior started to see it as low as 70 to 80%. And then it had this weird gap in the middle where 80 to 85% were not asymmetrical, but then it re-phased out and they became asymmetrical again at 85+%. So again, thinking critically here, like there's a lot of implications or different directions you can go with this. Now, this is just a case study. The authors even said, like, don't apply this to your individuals, but there is some interesting, at least, concepts here that can be applied to the future of your own rehab. Things to consider, things to be mindful of, the different forces. Maybe you're throwing on these different accelerometers, and maybe you're tracking these different things to see, okay, well, they did well with isokinetic and isometric testing, but I want to see how they're compensating. Maybe they look good to the naked eye, but the forces aren't lying. Their acceleration asymmetry is there. And maybe you want to spend a little bit more time in rehab trying to train out some of those things, as opposed to just saying, okay, well, they're strong and they put out force, so we don't need to hold them out any longer. Implications, the authors gave a few, but again, they were cautious to say, well, this was just a case study of one sample size, so don't take it for gold. But again, good publication and interesting things to consider as clinicians. First thing they said is the body weight definitely influences these asymmetries, and that goes for all of the different movement planes. So obviously being mindful of what body weight percentage you're having somebody start at or progress to. And this is pretty standard. I don't know anybody who doesn't progress body weight if they're going on to an Alter G, but just being aware that different body weights correlate with different asymmetries. So again, maybe you're looking from the side from that 70 to 85 percentile. And then after 85, maybe you're going back to a posterior view. Again, you have to use a little bit of clinical kind of experience or judgment here. There's not a gold standard or a protocol that's been put in place, but you can start to think about these things for yourself. And then vertical forces don't equal medial and lateral or anterior or posterior forces, and they showed the significant differences in those different forces at the different body weights. Vertical symmetry was achieved via the vertical forces, just the up and down forces that were put into the ground, before the medial lateral and anterior posterior symmetry was achieved. So being mindful that if you're just using a force mat or a force plate, your vertical forces might not show an asymmetry. But if you go have them run on a field or even on a treadmill on an Alter G, you might see some of those side to side or anterior posterior asymmetries, rotational deficits, things like that. Vertical symmetry increased with the player load. So they talked about how the player load is the accumulation of all of the different forces. And so even though they have vertical symmetry, maybe they're still getting some kind of a knee valgus that's increasing the acceleration of that medial lateral plane. And then isokinetic testing only happens in the sagittal plane. If you look at the gold standard, it's that isokinetic machine, and they're strapped into basically a hinge joint where they're only knee flexion, knee extension. What are the implications of this test in terms of translation to on-field work or on-court work if it's a basketball player, if they have to do side-to-side movement or curved runs or any kind of cutting, direction change, where you start to see some of these more rotational compensations instead of just your vertical force production. Last thing they talked about was the location of the accelerometer matters, and what they predicted came true. The lower leg saw higher forces and accelerations than the upper back, and this makes sense if you think about the kinetic chain. The lower body starts to absorb some of those forces, and they don't translate all the way up to the back, and so you don't see as many of these, especially the vertical and the medial lateral accelerations, because it's already been dissipated and absorbed by the lower leg, the quads, the hips, and then the back doesn't have to do the work, especially not up to the cervical thoracic junction, which is where they place that accelerometer. Questions, comments about the study so far? Cool. So in summary, again, this is just my way of thinking about it. It's not the gold standard, but different causes of movement compensation. These can be asymmetries, which can be caused by pain, lack of range of motion, lack of strength, but also it can be a motor recruitment issue, some kind of a neural detection issue. And then kinetic chain, always being mindful that ankle issues can lead all the way up to issues in the neck or head. And then also the different planes of movement, the sagittal, coronal, and transverse, not just thinking one-dimensionally through the sagittal plane, which is the norm. And then that is it for this week. Next week is talking about staff collaboration, so it'll be a little bit more of a administrative or structural approach to strength and conditioning. So how we do rehab handoffs, how we're collaborating with the strength and conditioning or sports science department, and kind of what our roles are amongst the rehab process. How we're working together kind of throughout the rehab process, but then also at the end stage where it becomes a little bit more involved on their end, how we can assist them, what they're looking for from us, that kind of stuff. All right, that should do it for this week. Thank you both for being here, and hope you got something from it. Hope you want to join more in the future, and tell all your friends and family that it's a fun time.
Thank you. This was great.
Awesome. Hopefully see you guys both next week.